Okay, good afternoon, everyone. You heard my voice a bit earlier on, but then I didn't tell who I am and what my name is. My name is Anders Nordström. I work in the Ministry of Foreign Affairs here in Stockholm as the Swedish ambassador for health, or possibly global public health after what I heard this morning. Public health is a keen interest to me, and especially the preventive area and what we can do, actually not just managing when people fall sick or stopping outbreaks, but also ensuring that that is actually not happening. I understand that you have had a good discussion now in the previous session, already beginning to speak about what we have seen during, it's not just during the last 3 years during the COVID pandemic, but during quite a few years when it comes to both global health threats, but also what is happening in our climate, but also what is happening in terms of conflicts. The previous session was about learning. This session will be about addressing and what can we do about this. And I'm delighted to be joined by colleagues from both Nigeria and the UK here in the room. And then we will have Mexico and Korea online as well. But let me just say a couple of words initially. When we speak about those threats, challenges, trends in society, whether it's pandemic, outbreak of diseases, the changes to our climate, or in terms of conflicts. And of course, we here in Europe, we see what is happening in Ukraine very much indeed right now. We often think about the direct impact on people's health. But I would like us now also to ensure that we speak about the indirect impact. Because the direct impact, one can think about that this pandemic is about a virus, containing the virus, and that's done. That's it. But of course, you know as public health people that that is not the whole story, of course. So, if you think about just what has happened to school children around the world, many children have not been able to access school now for quite some time. I saw in 2002 that 90% of children in Africa were not having access to normal schools, normal teaching. This is not just about the learning. This is also about health. Because the education, the level of education you get is a direct also relationship to actually your health outcomes. So just to think here a little bit in terms of, it's not just the direct impact, it's also the indirect impact in societies. Economies, what we saw during the pandemic, was of course not just that this costed a lot of money when it came to the vaccines that everybody were focused on, but direct impact here that we were closing the borders, trade stopped in many countries, people lost their jobs, or just the economic impact on families when they were falling sick and they did not have access to a good health insurance or a UHC system as we have here in Sweden. So the indirect impact here again is important to factor in, and I'm going to come to what I would like us to discuss during this session. You can also think about, if you look at what is happening in terms of our climate, and this is one of my personal passions right now, is that we speak a lot about the negative impact on people's health from climate, global warming, flooding, will we have more infectious diseases? But the most important thing is here that the trends in societies, the transition in societies that are taking us in the wrong direction in terms of our climate are the same ones that are taking us in the wrong direction in terms of our health. And then I mean primarily non-communicable diseases. The energy transition, more air pollution, the food transition, more processed food, more ready-made food, less healthy food, what we do in terms of urbanization and not always very skillful urban planning, contributing to the negative health and negative climate impact, but also our negative health impact. What we see in the world, if you look back, and I've been in this sort of work now for more than 30 years, if I look at the MDGs, we started then at 20 million people dying in the world, child mortality, maternal mortality, and the 3 diseases, 20 down to 8. When I began also then to make a reference to what is happening in terms of NCD, premature mortality from NCDs, I started just a couple of years ago saying that we have 15 million people dying prematurely from NCDs. Then I corrected that to 16. Then I was in a meeting with the Karolinska and the World Bank here on Tuesday, and they used the number 17. So that curve is going in the wrong direction. People dying before the age of 70, we should die, but we shouldn't die before age of 70. And our goal today is not just the MDGs, it's the SDG 3, which is about maximizing healthy life expectancy, ensuring that people can live long and healthy lives. There is research showing that if we're going to have an impact, unfortunately, the health service and the health sector is only contributing 11%. The rest is going to come partly from our genetics, but most importantly, what we are doing beyond the health sector. And that's why you as public health agencies, institutions are extremely important. What I would think would be quite useful here, we have a little bit more time because one of the speaker at the beginning will not be here, so we will have 4 presenters sharing experiences from 4 countries across the world. We will have time for more questions and interactions, both in between them and you. But just two things to think about. One is then, as I said, if we're going to have an impact on people's health, a lot what is happening beyond the health sector is possibly the most important. The question is how we can maximize that. How can we maximize the policy impact, the policy coherence, what we're doing in terms of climate and health, the policy coherence in between health and urban planning. I was reading a paper that is not out in the Lancet yet. Planting trees sounds like a very simple thing, but what does it mean in terms of more shadow for people when it gets warm? So when the heat waves hit the UK, people went to the parks. We need to think proactively how we design our cities. Green areas for children to be able to play and be spending less time on their phones, which they are doing today. So just to think about the co-benefits in a very practical, tangible way. Another example in the same paper was from Indonesia, where people have been cutting down the trees for many years, and that was becoming a big issue. And then people began to do some work to understand why. This was because they needed an earning. And why did they need the money, the earning? To be able to pay for healthcare, because healthcare was extremely expensive in that area. Okay, engage with the communities, and then they set up basically a very basic primary healthcare center, and rapidly you saw improve in terms of health outcomes. Child mortality went down, but they stopped cutting the trees because they didn't need that much money, and they found other incomes instead of that. So to think about, and that I think should, if we can speak about that, the sort of policy coherence, maximizing the policy impact, also recognizing that sometimes, of course, there are conflicting objectives for our different policies. But how can we maximize this? And again, you, I think, have an important, or we have an important role, really to, in some way, assist people to show where we can have an impact. Sometimes just also with our climate colleagues or our food colleagues, they don't even need to say what they are doing is good for health, but we can help them at least showing the matrices, the indicators that what you are actually doing is quite important for people's health. And if you would tweak it a bit, it could possibly be even better. The second question is, of course, then, what is your role here? Public health agencies, institutions. Some of you, I understand, are more focusing on non-communicable diseases. Some are focusing both on communicable and non-communicable diseases. It's a mixed situation across the world. But I would think that surveillance is the same, whether it's communicable or non-communicable diseases. But most importantly, behaviors, people's behaviors. How do we work with people? How do we empower people to enable them to make the right choices? Whether it's to wash your hands, safe sex, or eating the right food. At least when I had the privilege of being the head of the WHO country office in Sierra Leone during the Ebola outbreak, it was all about washing hands and checking the temperature. But we immediately began to see how we could work with people on other healthy behaviors. In schools, with a group of mothers, and it was not just about washing hands, it was also about what you're eating. We had a lot of people, children that did not get enough food, who were starving. On the same time, we saw that obesity began to explode. But then again, the win-win here, the recipe, what children should have, is the same. Whether you have too little or too much food, it's the healthy food that they should get. And it's basically the same food. So to think about those policy wins, coherence, I think is something, again, we can discuss what you think and what is possible from your perspectives in your institutions and agencies where you're sitting. But this should be about learning, and we will start by learning from Nigeria. Are you ready, sir? Yes. Then you are very much welcome, and we're very much looking forward to listen to Dao. Thank you. Very much welcome, and very much looking forward to learn from your experience in Nigeria.
Thank you. Well, good afternoon, everybody here, and well, good morning, good evening to other participants online, depending on where you're logged in from. Well, my name is Ifedayo Adetifa, just call me Dayo, and I'm the Chief Executive of the Nigerian Center for Disease Control. Today I'm just going to say a few words about, well, maybe my impressions of what it means to build back better from the impact of, well, COVID pandemic, but beyond COVID, which I'm often at a loss as to how to convince the media and other people in my country that COVID is the least of my problems, you know, and I'm not a COVID agency, but you know, when you talk about pandemics, COVID is the one that has touched everyone in a lifetime. And of course, we, as you know, certainly in Nigeria, we also have conflicts. We have security challenges, especially in some of the northern part of our country where this predated COVID and has acted to make things worse on top of with COVID added to that. And of course, in the same area and other parts of the country, we also have climate challenges, desertification. People know about the floods that we had recently, so it's multiple problems. This is the public health scene in Nigeria. So 200 million people or so, it's said, with still a massive population growth, almost 3% per annum. And then we've got this unique, well, not unique, we've got this scenario where, although there's a lot of emphasis on communicable diseases, we know that we have really big challenges from communicable diseases. So as listed, neonatal conditions, diarrhea diseases, malaria, lower respiratory tract infections, and the like. And what this does not say is that you have a near equal or indeed increasing burden of non-communicable diseases or the so-called lifestyle conditions. And then, so you've got all these problems in the mix, and alongside that is you've got an inadequate health workforce in general. Then you've got also an inadequate public health workforce. You do not have as much money to spend because the health budget is not reached the Abuja declared target of 15%. But the scenario is also one where you've got slightly also the same complexity to an extent as Sweden. We've got a federal government, we've got federating units, state governments, and we've got what would be, I don't know, sub-counties, but local governments, and there are about 774 of them, and 36 plus the federal capital. But more importantly, there are challenges with universal health care, and 75% of all healthcare funding is out of pocket. So that's the background. And on top of that, we've got to deal with all of these issues. Pressure on healthcare service delivery as a consequence of outbreaks, you know, which then compromise all of the years of progress that we have made in terms of HIV/AIDS and TB control. So we're seeing record numbers of TB case notification now. We are seeing a bit of an uptick in some centers for HIV new infections, and malaria just seems to always be there regardless of what you do to try and mitigate that burden. With the conflicts in place in different parts of the country, then you've got problems with access to care, you've got problems with delivery of care, and then, as I said, you know, you got the recent flooding. Well, it's not. the flood waters haven't quite receded in some parts of the country, and then we are seeing sort of cholera outbreaks and outbreaks of other waterborne conditions in that setting. But despite all of this sort of bleak picture, as they say, it's a matter of outlook. You either see your challenges as obstacles in your way, insurmountable obstacles in your way that you can't ever go across, or you indeed treat them as opportunities. And we choose to treat this as opportunities despite all of these challenges and the pandemic, to build back better, to consolidate all of that response, all of the good things that have been said into more resilience, and to coalesce all of the response investments, whether it's in labs or surveillance systems or in specimen delivery systems and other third-party logistics, into some streamlined, mainstreamed, cohesive functioning or more routine type functioning that then sort of contributes to resilience in the system. I think there were sessions earlier today where people talked about paper-based surveillance. We've moved completely to a digital-based surveillance system. This was indeed a change driven by necessity. So we sort of deployed first in response to monkeypox, then there was first in response to Ebola, few states, then there was monkeypox, another region, and then Lassa fever, and then, the good thing is that the impetus that was given or provided by these various outbreaks led us to finally, and then down to COVID, made us to finally achieve a nationwide spread. And for us, the next growth area, as somebody alluded to or touched on earlier today, is to make sure we now have this in every health facility and in every laboratory, and to ensure that surveillance and laboratory data really talk properly. So we are also working, the country's sort of giving the most important political commitment that it could by signing into law, enacted the law to establish the NPHI. And what we are doing is to make sure that we can put together all of those various domains that you have under the roof there into what we do, and to make sure that we just don't do well in a few, but we need to build capacity and ensure that we're able to deliver on all of those domains. So public workforce development is a major challenge and a recurring theme here at this meeting. As I speak, there probably will be files arriving on my table of people resigning from their positions. And it is far easier to resign than for me to hire replacements, even one for one. And the problem is also you lose somebody who probably sat through a monkeypox response, a seasoned Lassa fever responder, and I've got to hire some brand new person out of the packaging who now needs to be programmed so we're not just losing numbers, we are losing memory, we're losing capacity, and it makes it quite difficult in a situation where you are constantly struggling to actually get well-resourced in terms of your human capital so you can work, and then to train them, but as you train, the pipeline takes them out of the system. What this also means is that, and I think it's important that I mention that, is that I've got relatively limited bandwidth. Okay, so it's important when we think in the global health community or global public health community and research community of all of these interesting things we would like to do, that the African CDC will come to talk to me, the European CDC will come to talk to me, WHO is forever in and out of the background, then the researchers will come and talk to me. There's very little, and you're in a crisis mode, you actually do need time to reflect, to strategize, to paint your own picture of what you want the country to do and what your priorities are, that it becomes a bit difficult to achieve the right balance. And for me, we're getting to a point where I actually tell some partners, no, sorry, I don't want to have that conversation. it's a laudable idea. It's good, but we've got a lot to do now that we need to do properly and to deliver on, because otherwise what you get is Lassa fever surveillance. You go that way. Somebody's interested in dengue. You go that way. And what then happens is that you're not able to coalesce all of that into some coherent national surveillance system. So I just thought I should mention that and to sort of highlight to my colleagues from our part of the world that we do complain about funding as an issue. But I think funding is just one of the issues. The bigger issue is we really do need to be more strategic and paint a vision of what we want. So assuming you had no resource constraints in Nigeria, in Pakistan, in Somalia, what kind of surveillance, national surveillance system do you want? It's important to set that vision, to decide now how you want that system to speak to your animal health sector surveillance system and your environmental health sector surveillance system, even if they don't exist. But the idea is if you at this time set the tone and sort of your APIs, which is your, I don't know, the IT guys talk, is basically the technical specifications for your surveillance platform that that others need to meet to be able to have the systems be interoperable. But this is the time to actually make those decisions so that when somebody comes to offer you a bit of money for some disease-specific surveillance, you can say, look, that system needs to be able to do X, Y, or Z. So we think going forward, we need to invest early in health emergency preparedness before the crisis, obviously. It's cheaper, you have more time, you're not under pressure, okay? We need to leverage on these challenges to strengthen the healthcare system, because no matter how much you invest in EPR, all of that rests on the building block of your primary healthcare and everything else you have going on, and that's where the resilience comes from. So if you don't have those in place, or you focus only on response, we need to train rapid response teams, but the community healthcare workers are abandoned or volunteers are not paid, then you really will not get the kind of resilient system that you need. We need to, of course, get integration around NPHI function. And believe it or not, just as we talk on a global scale about we will only be as strong as our weakest link, or a problem in one country is a problem for every country, it's the same thing in my federating units. So I can do a national JEE and get relatively good scores, but what's happening in my subnationals? Okay, and do the subnationals actually appreciate what it looks like to actually have what you should put in place to respond or to contribute to national health security? And that's actually an area that we are focused on. We've created an entirely new department for subnational support, and we are implementing a subnational or state level JEEs just to make sure that all of the component units know what they're supposed to be doing. Okay, I think that's it for me. Thank you.
Thank you very much. Please stay. We have time for some questions.
Well, just to say, the standing ovation looks quite good from here.
Okay. First, two questions for me. Looking back, you were looking back at monkeypox, but I would look back at polio and all the infrastructure that was in place. Now you've been very successful in terms of containing polio in Nigeria, but how important was that in terms of logistics, epidemiologies, capacity, competencies for what you're doing today?
I think it's a valuable question, and I think I probably, it's a bit of an oversight not to speak about the investments in polio eradication, because, for example, that system set up for AFP surveillance and the PHEOCs was quite instrumental in our Ebola response. Okay, the polio EOCs were some of the first examples of any sort of emergency operations platforms, and we built on that to actually convert this into fully fledged PHEOCs, or to use that to respond to meningitis in 2017, in 2007, 2017, and like. So they were very useful, and it is very important. If we didn't learn the lesson from polio investments, we need to learn the lesson from COVID that all of those investments, you need to basically do the work of integrating, further integration, and keeping them going. Yes, the same amount of resources may not be available, but it's our duty to find some adaptable ways of keeping the same function going, but hopefully at a fraction of the cost.
So a threat to crisis, a big challenge, could also be a way of strengthening your system, basically
Absolutely.
long term. And I think there is a colleague actually of mine from Sierra Leone here. Is she here? I saw on the list. Because what we did during the Ebola outbreak in Sierra Leone was doing exactly what you were doing here, investing in the integrated disease surveillance system, so that you had a system, and that, I mean, the ministry together with WHO, etc., we did that during actually that the outbreak actually was still ongoing. So we were focused on that. But my second question is that you said that in some way you would like to be left alone to be able to paint your own picture, your own vision. And we saw the house here.
Yeah.
But what would be different if you could decide yourself then?
Well, let me just qualify that. So what I'm referring to more important is perhaps the time for strategy and reflection. To understand that on the timeline, there's significant concurrent challenges. So if you take my situation, so I was sitting down not long ago responding to reports of diphtheria. So I'm in Sweden, and I'm being told about diphtheria cases. I still have an ongoing problem with cholera. I've got to deal with meningitis season and Lassa fever season. It's a lot to deal with. So you don't have enough time to actually reflect and strategize as you would like to. Also because you don't have enough bodies typically to delegate work to. Okay, so it's against that backdrop you have to deal with invitations to meetings, people who want to do one thing or the other. And sometimes if we are not deliberate about what we want to do, what happens is what I think it's I don't remember which of my colleagues describes, I think from Pakistan, is you get funders pulling you in every direction. So that is the issue, is that you need to decide for that building, what will my integrated disease surveillance look like? Okay, if I didn't have any resource challenge, and if you've made that decision, then I'm quite happy to take a contribution to that picture, that puzzle. If somebody comes with a puzzle piece for RSV, okay, so you have people who are trying to talk to us about RSV because of the triple threat of RSV in the winter season in the northern hemisphere. Do I pick RSV over pneumonia and other bacterial pneumonia and meningitis or Lassa fever? So, so these are the challenges to contend with.
Just to disappoint you, that we actually have the same problem here in Sweden, actually to find that time to strategize and to think. I mean, I think Karen can confirm that very often, I mean, there are new things happening every day. So we have always sort of those small emergencies, not so much driven by the funding, more perhaps by the politicians, don't quote me. But I mean, there is a constant lack of that time, the quality time to be able to sit back, to make the analysis, and to think about what would really make a difference. And I would say that you're not alone in that. So that might be something, again, to discuss in between agencies, how to find that time, basically. We have time for some questions or comments, please. Then we need a mic here. Somebody has got mics. Mics are coming there. And then if we can prepare the other mic at the end then, at the back.
So I'm Ilesh Jani from Mozambique's National Institute of Health. And I really, I sympathize with what is being discussed about the pressure of new subjects. But I think one important player there is the media. And many times the political agenda is also driven by what the media is talking about. So one of the things that I think we have learned during this pandemic and other crises is to boost the capacity of the Institute to deal with the media and also to communicate better with the society and with the policymakers on what the media is talking about. And I think if possible, to establish like a long-term relationship with the media also helps to educate both the institute and some people that work in the media in order to many times prevent amplification of non-existent crises.
Should we take the other comments as well? But just adding to that, I would say people's anxiety, which is really behind this or triggered by that. But it would be very interesting to hear how you have been sort of thinking around that. Yes, please.
Good afternoon, everyone. My name is Paul Kennedy, and I'm from Liberia. Doc, thank you so much for your presentation. If I had my own way, I would just pack my bag and go home now. Because apparently your presentation has struck some of the major challenges we have in Liberia. Ebola came and we suffered almost 4,000 deaths to Ebola. US CDC came and helped to set up a public health infrastructure we have now. We've trained a lot of few epidemiologists. Some of them are leaving because they are demotivated, lack of salary, lack of money. Government is always looking around to see how we could pay. Outbreak comes and we panic. But one thing we've not been able to do is to have the immediate resources to respond while we look around to get support. So the question I was going to ask is, the Nigeria CDC looked into establishing a pool fund or escrow account somewhere where you could put money in time of peace, just in case when you have some urgent need to respond to an outbreak, you can immediately begin to use that money as the initial funding to move logistics around before the World Health Organization or the rest of the world can come in. And if this IANPHI could think about how they could help low-income countries with holding, some money somewhere where you can immediately provide initial support before the rest of the world come in. Because most often, we've already noticed that thousands of people die prior to any aid coming in the lack of the immediate resource to respond.
So question about media and money.
Okay, good questions. We have, what my colleague from, did you say Zimbabwe? So what she said is right. We have actually invested quite a bit of effort in, again, as a lesson from COVID, in what we now call infodemic management. So we conduct surveillance for infodemics. I've got a team that develops the appropriate response or press releases or media effort or community engagement, depending on what the intelligence is. We've invested in, of course, media training. If for my colleagues, it might seem to be not important, but in NPHIs, you do need to have colleagues that are trained to respond to the media. And for us, it's a bit of an urgent strategy to make sure that we increase the numbers, because actually the demand for speaking to the media is increasing, and we recognize the value of that engagement. So I tend to the extent that it's possible, speak to the media as often as we can, because what happens is when you don't respond to that need for information, they just go to town with whatever story they want to say, and then you might get something like sources in the NCDC refuse to comment, which then sort of heightens community or population suspicion. And so it's just better to communicate openly and transparently about the things that we look after. So that's I think, is a good point. To Paul, so again, from previous outbreaks and from this one, we learned a lesson about having access to a quick pool of funds. So for when COVID struck in Nigeria, I think the government first had to depend on the private sector, were the quickest to be able to mobilize funding before government funding came on board. So what we now have, we've got a provision, a pot of money called the Basic Healthcare Provision Fund, which has a proportion that statutorily goes to the NCDC. And what we have done is that about 80% of that funding now, we are keeping in what is a public health emergency response pot, okay? Just so that And I think the guidelines for release actually say that I, as chief executive, as long as I've got good cause to spend it, I can spend and then, of course, notify the Honorable Minister for Health. So that's one thing we have. The other thing is also we've worked with, so sometimes when partners come to you and ask what you want, is you can tell a partner to keep aside $50,000 for you to access in case you need to respond to something. And we have some partners who intermittently are able to guarantee that you have that kind of pot of funding. The other thing again, it's a bit of a balance. Do you keep resources aside when you have immediate problems to deal with? Okay, so do you prepare for what's coming and not solve what is on ground? So that's something you're going to have to contend with in your setting.
An insurance modality. So, I mean, this is about how we can address better in the future. So two things, having a strategy and competence for managing infodemics, and both right kind of knowledge, but also people's anxiety. And the second one is to have some pre-allocated funds will help. Yeah. Thank you so very much. We should move on now to different parts of the world. If we are lucky, we will have Mexico with us. Mexico. This is a little bit like the European Song Contest. Mexico, are you with us? Can we hear your votes?
Aye.
We have Sergio, and Sergio is the Director for Health Economics at the Institute of Public Health in Mexico. Can you hear us?
I can hear you.
Very good.
Thank
Very
you.
good. We can hear you. We'll see whether we'll be able to see you as well. Now we can see you. Excellent. So very much welcome. I hope you've been able to hear a little bit at the beginning of this discussion, but trying really to understand more both what have been the impacts, both from climate, pandemic, and conflicts when it comes to economics, but also what we can do about that. What are the lessons to be learned and how we address it in the future? The floor is yours, please, Sergio.
Thank you. Thank you very much for the invitation. What I would like to do is to talk about the work we've been doing at my institute. I work, as it says here, in the National Institute of Public Health in Mexico, in assessing the indirect impacts, the indirect economic impacts of the COVID-19 pandemic. We think this is important because having a sense of the magnitude of these effects that I'm going to show you help us in many different ways. Mobilizing resources for preventing this in the future is probably one very, very important. So we're all aware of the economic impact of the COVID-19 pandemic. We were just hearing about it in the introduction of this session. This graphic shows the relationship between stringency in lockdown in many different countries in the first 2 quarters of 2020 and the negative growth of their GDP. So there is, according to this estimation by Oxford Economics, we can explain about 2/3 of the economic impact just by lockdown stringency. So there's a direct impact between the measures we had to take to contain the epidemic and the changes in the economic activity. And here, according to the Brookings Institution, this impact is much more important in emerging markets compared to advanced economies. So the effects are not only very large worldwide, but also distributed differently depending on the size of the economy, and low and middle income countries had a very, very strong impact, a negative one. And here I'm showing you data from my country in Mexico. We can explain a lot of these effects in the economy directly by employment. Here we see the rates of employment, people employed in Mexico, and we can see how employment decreased, unemployment stayed stable, but increased substandard, occupied types of jobs. So this is a direct impact of the pandemic on the economy or in the economies in many different countries. And here you're seeing Mexico's data. What we wanted to do in my institute was to assess an indirect impact from the pandemic, also immediate, but it's an impact that is less talk about, and for many reasons. One is that it's not easy to estimate. The other is that it's really very difficult to talk about and discuss the implications. But we thought it would be important to see what happened to the economic impact linked to mortality during the year of the pandemic in 2020. What I'm showing you here is the number of premature deaths in Mexico in 2020. And I'll show you data on the deaths due to COVID. But I'm showing you here the premature deaths due to other diseases. And what we can see very clearly here is diabetes, coronary disease, and hypertension. All of these diseases as cause of death increased in 2020. So these may have not been classified as COVID deaths, but these are clearly related to COVID, because we can see on the right premature deaths due to other diseases like liver disease or stroke basically did not change. Another one that is not COVID, but also show a great increase in Mexico was lower respiratory tract infections. This one more than double in 2020 compared to previous years. And these are only premature deaths. This is not total mortality. These are deaths that occur before they should have, according to life expectancy in Mexico. Here on the right, I'm showing you other causes of death that didn't change, and even a couple, for example, gun violence, which is a terrible problem in my country, that actually decreased due to the pandemic because people were inside their houses and for the first 2 quarters of the year. But the point here is that in addition to COVID mortality, we had great burden of premature mortality due to other diseases, chronic diseases related also to COVID. And one can assess, if we look by age group here, the difference, the change between premature death and one translate premature death to actual potential life, years of life lost. If you see the difference between 2019 in red and 2020 in blue, you can see the increase in life, years of life lost in 2020 due to, for example, diabetes, lower respiratory tract infections, ischemia, and hypertension. So this is not only significant increase in life lost, but also a significant increase in productive life lost. And one could view this as a productivity lost for the country. These were people who were, many of them, for example, you can see here in lower respiratory tract infections, people in their more productive years of life died because of the pandemic. And when one see the COVID mortality, the picture is a little bit different, but not that different in terms of the number of years lost in these ages. So one way to assess one of the many indirect impacts of the pandemic is to assess the value in terms of productivity of these years of life lost. And that is what we did in this work. And sorry about that.
Okay.
Sorry, that's Lola. So we did exactly that, and we assessed the total cost due to premature mortality in Mexico in 2020 and compare them to 2019. And what we can see here is that you can tell a cat what to do. Sorry about that. But also that the loss of productivity because of COVID, I'm showing you COVID here because obviously we don't have premature mortality before, but we have all the premature mortality in 2020. And if you look at the first 6 causes of premature mortality in Mexico in 2020 and assess the value in dollars, because of the average productivity of the potential productivity of those people who died, just accounting for COVID-19 mortality, diabetes mellitus, ischemic disease, and lower respiratory tract infections represents 2/3 of a percentage point of GDP in 2020 alone. And we thought that was an important thing to assess in Mexico. This is per se information that could be useful for policy purposes, but also we think as an input for other types of analysis assessing the economic impact and needs to prepare for the pandemic. Thank you, and sorry about the interruptions again.
Thank you very much. Thank you very much, and also a big thank you to Lola then.
Sorry about that.
Now time is running, but still we have time for a couple of questions. I was intrigued by when you started speaking about the impact of lockdown on the economies. And then so I was sort of thinking about how much, is it possible to think about the trade-offs here then in terms of different kinds of mortality? Because obviously, definitely, we've seen in very many countries that what we've seen are not just, as I said initially, the direct impact in terms of how many people have been affected by COVID and how many people have died, but we also now know, and especially with the figures you showed, that we have seen increased mortality, premature mortality for quite a few other diseases. So the question is, where if we as public health experts know this, how can we advise policymakers here in terms of the trade-off? And I was thinking specifically of the economic impact here, and as this is the theme here about lockdowns, not lockdowns, economic decline or not, and what impact that has also on people's health. And if then you look beyond just this virus, but also look at health more broadly. Do you have any comments on that, whether that has been part of your discussions in Mexico?
Yeah, that's a very important question, because obviously at the time we or officials made decisions based on the best data they had at the time, and at the time I was part of the group advising my government, and at the time the evidence we had to make this very difficult decision was that increasing the stringency of lockdown early was probably the best alternative. And we had evidence from a couple of papers looking at data from the flu in 1919. That's what the data showed, looking at specifically at the economic impacts I'm talking of. Of course, there are other considerations related to saving lives, because that's an important goal per se. But just thinking about the economic impact, what we had, the evidence we had at the moment show that the economies that increase prevention measures early could have a better chance to reduce the long-term impacts and economic impacts. So I think that's what most of the countries, at least in the hard-hit areas considered, and that's what most of the decisions were in that direction. Obviously, there are a few exceptions, some very notable, but I think that was a good decision at the time. Now we will have more and more evidence, and to assess these trade-offs in the future. And I think this is one very important one. The mortality, the economic impact of mortality due to not only the pandemic directly, but many other causes of that. And
thank you. I think we need to move on, but stay with us,
Sure.
and we will have hopefully a few minutes at the end.
Thank you.
I mean, personally, I don't think this was possible politically to say anything else than do maximum to stop the COVID, even if you know that we will have indirect impact on other health conditions. So I think for public health professions as we are, I mean, this is an extremely important lesson for the future, what we've heard here, and to see whether one can say, do a bit less on the outbreak next time and make sure that we save the other lives as well. Difficult, but possibly something we need to say. Now we will move to another part of the world, and we're extremely grateful to Dr. Jujin, who is awake. I mean, this is quite late, I think, in South Korea now. If you are you in Seoul? Because then it must be in the middle of the night there. Are you with us?
Yes. Good afternoon. Actually, as you mentioned, Korea, we are now on uh, 2nd December. So, well, anyhow,
You have
I'm
always
very,
been ahead of us.
yes, and I'm actually anyhow, I'm very happy to have an opportunity to participate in this important meeting, and it's my great honor.
So please
So,
share with us
yes.
your experience and advice for the future, because South Korea was really one of the countries that did what was said before, an early aggressive containment of the outbreak. But the question is, what are your
Yes.
lessons here when you look at this from a broader perspective?
Thank you for saying that. Well, I will start my presentation. Well, as introduced, my name is Yoo-jin Jung, Director for International Affairs at Korea Disease Control and Prevention Agency. Well, my presentation will address the economic impact of COVID-19 in Korea, as well as importance of prompt and effective response in the early stage of the pandemic, by reviewing our strategies during COVID-19 pandemic, as you mentioned. Well, additionally, I'd like to introduce what we want to do for preventing, similar, when we face the similar impacts or next pandemic in the future. So this is the graph about the economic impact on Korea during the COVID-19 pandemic. Well, I would like to mention a report released in May 2022 by the Korea Institute for Industrial Economics and Trade. Well, according to this report, when you compare the past major crisis with impact on COVID-19, the decrease in real GDP growth caused by COVID-19 pandemic was similar to that of 2009 global financial crisis. And the shock in consumption is the second largest, following the 1998 Asian financial crisis. Just for your reference, the magnitude of the impact was derived by comparing the trend value of 5 years with the year value of the lowest point. Well, the graph on the right side shows the decline of the real GDP growth rate and the private consumption rate in 2020, respectively. So the trend of GDP growth rate and the private consumption over the previous 5 years was it is 2.8 and a 2.5% respectively. However, each of them was 3.7% or 7.41 percent point decreased in 2020. Well, the report assumed that the impact on consumption was greater than the drop in the domestic GDP growth because the COVID-19 pandemic had the biggest impact on face-to-face service consumption due to the characteristic of the threat of infectious diseases. Well, this is the graph on the of the um, real GDP comparison. Well, according to the same report, if we say the GDP in the first quarter of the 2015 was 100, the real GDP in the second quarter of the 2020 decreased to 95% due to the COVID-19 pandemic. But after the third quarter of 2022, we entered the continuous recovery stage and the real GDP increased to the level just before the pandemic in the first quarter of 2021. The 2022 OECD report assessed that Korea's management of the COVID-19 pandemic protected the people and economy and stated that per capita GDP exceeded the OECD average for the first time, followed by the export-led rebound in 2021 and early 2022. In particular, the 2020 OECD Korea Economy Report reevaluated that Korea was the most successful country to contain the spread of the virus and achieve the result without lockdown, minimizing economic damage. Well, as you mentioned when you introduced me, well, Korea adopted very strong response measures at the early stage, especially. Well, we called it our strategies 3T, but 3T means test, trace, and treatment, but we called it traditionally TTIQ, tracing, test, tracing, and isolation and quarantine. So I think the basic conception of the responses is not that different. Well, Korea adopted at the initial stage really strong containment method response system. We just want to expand our test capacity to detect the patient and suspected patient really early stage and avoid additional spread to other people. So we are really focusing on test and tracing at the early stage and really try to contain as rapidly as we can. But after the Delta variant, we changed our response measures, adding the social distancing measures and vaccination. And after Omicron, we changed our, I think it's most similar with other countries, but we changed our response system to mitigation. So, well, until the time, so after the Omicron epidemic, Omicron variant, the government promoted the recovery to the daily lives and efficiently rearranging resources for pandemic response and switch to the general medical system. So after the Omicron, we are using our healthcare system to just respond to this Omicron variant and lifted almost all the measures, countermeasures, except masks. So what we have learned during the COVID-19 pandemic is that a swift initial responses has the immense impact on successful control of the overall spread of the virus. Well, I will explain further about these lessons at the next slide, but we'll realize that the initial stages responses has a lot of impact on the economy and social areas. So we learned that we have to focus on this matter to prevent the next pandemic. And also other factors, there is other factors, the preparedness of legal and institutional frameworks is really essential. And the governance for whole of government approaches also needed. And to for the early stage responses, the rapid scale of the responses measures, such as the testing capacity or tracing capacity, and so on, are so essential. And with in order for that, the public-private partnership is really crucial. And lastly, we have to enhance our capacities of the NPHI and securing public trust. So, according to the COVID-19 index, the Korea maintained a relatively low fatality rate from the beginning of the pandemic until the introduction of the vaccines by using the various pandemic response policies. So, the cumulative death before the spread of Omicron variant was 10% of the total death in Korea. So uh, the death in Korea because of due to the COVID-19 was not central, not how can I say, the death is not caused at the early stage much, but rather than the after the after Delta and Omicron. So this shows the difference. This is quite different to other countries that have a high fatality rate in the early stages of the pandemic. So at the end, um, the OECD evaluation says that the rapid response in the early stages of the new emerging diseases epidemic can be considered to be the key factor in minimizing economic shock in Korea. Well, I am not quoted the other reported, but we can see many similar ideas from other documents as well. For example, according to the Doherty Institute 2021 report, said that the optimal TTIQ strategy can minimize the needs to public health, social distancing, or public health measures.
I think we should allow for some questions as well.
Yes.
Uh,
Yes. Okay.
thank
So, what we want to say that we have to strengthen and focus more on the our capacity building for the initial for all of us to make our efforts at the initial stage. So we have to back to the basic, the test capacity and trace capacity. Those are the key factors for us to uh, prepare for and respond to the post-pandemic. So what we have to have do is now that the as there are three components. So in domestically, the problems and limitations identified during the pandemic response period will be supplemented by continuous system improvements and organizational capacity enhancement. And the multi-sectoral cooperation with other ministries and private sector partners are also seeking. Internationally, we would like to contribute to the development of better response strategies by sharing Korea's experience through various international cooperation, so that the international community's ability to respond quickly to infectious disease spread. So
You and I think you're doing that just by what you've been sharing here now. So just a big
yes.
congratulations to
Okay.
what you did, Korea, during.
Thank you so much.
Yeah,
So
thank you.
that's what we want to say, and thank you for joining. Thank
But
you
please
for
stay.
inviting
Please
me
stay.
today.
Please stay.
Yes, yes.
Please stay.
Okay.
Thank you.
Thank you very much.
I think it should be just noted what Korea did not do at the initial state, this sort of early containment of the outbreak. They did not do any lockdowns. There were no major lockdowns.
Yes, you're right.
But it was aggressive, targeted stopping of the spread, but no lockdowns. So it's an interesting experience. And when I was working with the independent panel, this was one of the best examples. Then we did 28 country studies. They are published in both in the Nature and BMG. And I mean, the countries did basically what Korea did. A question or questions from you two colleagues here in Seoul. I mean, a reflection or would be an interesting question to you is that, I mean, those figures when it comes to the money where we began are quite strong. In some way, health is money. Will you be able to convince your Minister of Finance with those figures now to invest more in health?
Well, I think that is the governance inside the Korea. So from the very early stage, we organized the governance centered by Prime Minister. So all the ministers and local authorities joined the everyday meeting, morning meeting, to organize the resources. So this kind of whole of government approach is much essential for the next pandemic preparedness.
Thank you. But just to see, do we have any comments on this or questions from you here in the room? Yes, please.
Did the government increase the financing of the Public Health Institute of Korea? And the same thing applies in Nigeria and other places, was money not for health, because globally money for health has been reducing because of policies of privatization and the World Bank and IMF conditions. But the question is, for public health, was it increased in Korea and Nigeria?
Practically for you, for your institute, you have a bigger budget now.
Well, actually, our budget multiplied seven times from during the COVID-19 pandemic. So
Okay. Did you hear 7 times?
Yes, 7 times during the COVID-19 pandemic. Well, this amount of money contains the vaccine purchase as well as the diagnostic tests,
of course.
and so on.
Yeah.
So, but we invest a lot.
What will it be next year then?
Well, next year,
No, next year.
You mean 2023?
Yes.
Yes, it'll decline a little bit, but still we have vaccine purchase budget and other things. So
those are extraordinary costs.
Yes.
Okay, thank you very much. We are coming close to the end, but now we're going to go to the UK. And I mean, also very exciting or interesting to learn about now the UK government. Is the government going to invest more in health? You didn't expect that question, but it would be interesting to learn now from the UK. Thank you.
Thank you.
Very much welcome, Jenny.
Thank you very much. I'm really excited to be here. I have met many of you, but this is my first proper IANPHI meeting. So I'm Jenny Harries. I'm the Chief Executive of the UK Health Security Agency, and I think I'm going to start an empathy club with Dio after this, because we both have just been in post a year, I think, and I recognised a lot of the issues that you raised there. They're good ones to consider. So I'm hoping if I say move the slide. but I'm trying to move. Can you do it? That would be easier for me because I've got my notes on here. As I started, I would just like to say at the start of this, I think it was Marikan who said at the start, I am very humbled by many of the presentations that have been here from Dio, from Mr. Ahmed, and particularly I think from Alexander. So when I talk about problems in the UK, they are in no way the same problems which others are dealing with. That said, I think there's still some learning from the pandemic that we can raise. And what I'm going to do is talk a little bit about economic issues, if you like, in the UK, but then I'm going to try and end, as this is the last slot before everybody goes off to the reception, I'm going to try and end on some of the positive things that I think we are now doing as a result of the pandemic. Yes, so on this slide, what you can see is that we are a new organisation. We are built from the scientific part of Public Health England, a new organisation, the National Test and Trace System, which was very heavily funded by the UK government to deal with contact tracing and testing at scale. And then another section of this called the Joint Biosecurity Centre, which is now part of the UK Health Security Agency, which focuses on data analytics and surveillance. And what this does is gives us a real opportunity as we go forward to use all of those skill sets and the recognition, particularly on the earlier part about integrated disease surveillance, to have a completely new approach to health protection in the UK. Now, we do not routinely deal with non-communicable disease, but I'm from a general public health background, and I am so aware that there is no black line that you draw between infectious disease and non-communicable disease, and in many ways, increasingly, we recognise that one switches into the other. So we have a remit, and on the slide you'll see some of the areas which I think have already been identified for the organisation to build. And we were born in the pandemic to fight the pandemic while it was ongoing and to prepare for and respond to threats in the future. But we also have a particular remit to build capacity for the future, and I think that's a conversation that many of us have been having here. Next slide, please. Now, had I recognised that we had a proper economist on the line before I was coming online, I may not have been brave enough to put this slide on. However, I did do a very, very long time ago some health economics, and I had a bit of a light bulb moment when I was doing that around production possibility curves. And I'm not going to go into the detail, I will inevitably get it wrong. But the basics here is that if you put two bits of something, your costs and your capital goods and your consumer goods, or however you want to translate that into health terms, the economy doesn't have enough factors of production to produce output beyond that frontier, that bit on the right. So you have, if you're operating inside the curve, you're not being as efficient as you can be. Now, when you're talking about producing goods, whatever it may be, widgets or something coming off a conveyor belt, that's quite easy to understand. But I think, as has already been mentioned, there are huge opportunity costs, which is why I think the career presentation that we've just had is a really important one. The timing of what you do and how you do it and what those opportunity costs are. And if I quote the UK's own Chief Medical Officer, Professor Sir Chris Whitty, he has always said, which I totally agree with, that with COVID, when decisions have been made, there has been no good outcome, just a least worst outcome. And I think this is what we need to remember when we look at the health economics and the impact of the pandemic. So next slide, please. So we have had a lot of change in the public health system in the UK, and we have, you may have noticed, we have been changing our prime ministers and our secretaries of state for health fairly rapidly. We now have a new one, and in fact, I have a new public health minister as of yesterday, I think. So there is lots of opportunity to inform lots of ministers across government, which has to be a really good thing to do. But the COVID pandemic has had lots of economic repercussions with widespread implications on things like global supply chains, which I know we've all experienced. But Obviously, there are other things which we have had mentioned through this presentation. So extreme weather events, the unprecedented flooding in Pakistan, just as an example on climate change. And we need to understand that those health impacts are understood, and conflict is never far away from many nations. And it gets hard all the time, as I think we've all said, to stretch the reach of the public health investment as we go forward. Now, if we look at the next slide, please, and what's happening in the UK at the moment, I've just picked out three main issues. So the first one here is the COVID-19 pandemic, and there is the obvious cost in terms of lives and disability. But actually, we are now seeing quite a significant excess mortality coming through, and the rationale for that, the actual reason behind it, is not entirely clear. Now, all through the pandemic, we can expect various changes. You can expect secondary impacts from those individuals who haven't been able to access health services, or perhaps felt frightened to access them. So if you didn't have screening, if you didn't have vaccination, they're likely to come through later. But actually, it also has a disproportionate impact on the UK workforce, and I'll come to that in a moment. But in addition to that, if we look at climate, for example, in the UK, we have recorded this summer our highest ever temperature. Now, it may not seem very high to many of you, but 40.3 is extraordinary for the UK, which is usually pretty wet and cold from my recollection of childhood. And that change was 1.6 degrees higher than the previous highest temperature, which was set in summer 2019, when it was 38.7. Now, clearly, it will not be a straight line, but that increase is quite phenomenal. And we did have fires in the summer, and I think for the first time ever, the UK public saw climate change in action, the things that many of you will be experiencing in your own countries. And whilst we don't want that, it actually has been a very visible reminder, a real reminder. I've noticed that the conversations about climate change and the climate change skeptics has disappeared almost completely in the UK since this has happened. The other important thing is, of course, is that as we rise, those temperatures rise in the UK, we have very poor adaptation in our houses, because they're all designed to, well, they're poorly designed, whichever temperature you use, actually, and I'll come to that as well, but they certainly don't work for hot weather. We've got lots of 1960s buildings and various other things. And so then I've just been given a 5-minute reminder, so I shall speed up a little bit. But then the financial crisis is really important, because we are currently running at the highest inflation for 40 years, and that's having significant impact on people's daily lives. And I'm just, next slide, please. And the reason I just want to flag this slide is just to look under the numbers, because while we think of the economy, on the left here you can see the change in GDP and output, and in contrast to Korea, you can see at the end the UK is into recession. But if you actually look as well at the likely behaviours of people going forward, it's very different. So on the top left-hand graph, you can see online sales. That means people are not going to be buying things or accessing them in the same way. On the far right, you can see the footfall. So our retail sales have recovered. That's the green line at the bottom. But people aren't going out to buy their things so much. And so that will affect the different economies. And we have had a particular hit on things like air travel. Good for sustainability, not good for the air industry. But if you look on the left, the middle one in the bottom, you will see that the furlough was the financial scheme put in to save jobs, but actually it hasn't managed to stem the demand for healthcare workers, where we still have an undersupply. Next slide, please. So just looking at those three factors, infectious disease, this is a piece of work which highlights, it's a systematic literature review showing that over 58% of human pathogenic diseases are actually aggravated by climate hazards. We need to remember that as we go forward. Next slide, please. And then the issues to do with inflation, it's currently over 10%. This is something which our young people have never experienced before. And it's gone alongside a sharp increase in global energy prices. And those inflation effects are starting to really be felt by families across the UK. And that's coupled with, on the right-hand side, a complete change in our workforce. So there's been a huge change in the over 50s who are deciding where they're able not to go to work, and many of them are not going to work because they now have longer-term disabilities. So the whole pattern of the economy is changing. Next slide, please. And when we look at that, you'll see on the top side there, we actually have now got a program in where GPs are prescribing heating. And that's because you can see on the bottom right that the cost of a therm of gas in the UK in 1 year has risen 6-fold. So the impact of fuel poverty subsequent to the whole combination of people, if you imagine you've had COVID, you may have long COVID, you have very little income, you may have been furloughed, your costs have gone up by 6 times, and your GP is now picking up those individuals who have cardiovascular and respiratory conditions and in poor economies. And you can see here, this is the impact. You can see the coldest homes in blue, and you can see as our summer hits in the difference goes off. But as the winter progresses over on the right-hand side, you can see the impacts in terms of risk of death relative to summer. And you can see also the dark blue colours there, they tend to be in Cornwall on the south, in Wales, and in our poorer northern areas. Next slide, please. So I look back, and there was a World Bank document in 2017, which was just after Zika, and I think we're all recognising this. It highlighted some of the health impacts of pandemics and significant disease events. And then on the right-hand side, it actually highlights many of those issues that I think we have just been referring to. So the first one, of course, is that governments, the further away they move from the pandemic, don't recognise the fact that you need to keep investing and you have to keep putting in resources. There's a very high uncertainty of direct reward from many of the investments that we make in health protection, and there are competing programmes, and they will tend to go for the things which have an immediate impact. And then finally is the multi-sectoral element that we need to remember, that all of these things interdigitate together. Next slide, please. So point number one, I think we all feel, and maybe that we're all biased, of course, that public health is underfunded, and that presents a very big challenge for us all preparing for major public health threats as we go forward. And we do need a different approach to this to deliver our remits and responsibilities. And in answer to Anders' question, we had a very significant budget for the previous year. Our first year as an organisation, we've had a good budget. We do not yet have a budget for the following years. And that obviously, I think, is where many organisations are. Next slide, please. And then obviously climate change will affect our economy alongside changing the threat landscape. And I can see that we are running a bit short of time. The thing I'd really like to point out is here that where we have a fiscal constraint, then having something which is a low-cost solution is a much easier one to sell to politicians and with having wider impacts. So I'm just going to say 2 or 3 slides about what we've been doing in the UKHSA. So next slide, please. I've tried to take a different approach as we go forward explicitly. So on the one hand, on the right-hand side, we are the Health Security Agency. We are, if you like, the insurance policy for the nation ready to respond. But on the left-hand side, I don't think we have sung about some of the scientific and technical skills that many of us will have in our organisations. And so this bit I am highlighting both to the public and to ministers and to industry, because this is our economic growth card. So on the one hand, they need to invest to protect, but actually we can contribute to economic growth through our scientific prowess. And so there are 2 slides here with the things that we've been doing. Next slide, please. So the first one is, although I've put working with industry, we have taken in what was the UK Vaccine Task Force. This is really the lessons learned about everybody working together. And if we're working closely, whether it be in the UK or right across the world, actually there are opportunities to guide what pharmaceutical companies are doing if we also are guiding them by the public health impact that can be achieved. I know there's a wider conversation, not for here, but there are some good ways now, I think, with new vaccines and new products coming through of working together on that. And we have started a new Centre for Vaccine Development and Evaluation, which has largely kicked off during the pandemic. We've been working much more closely with ministers, and I think that applies to many. And I take the attitude, if you're in the room, you can influence. So that has been positive. We've also just started completely new, a Centre for Climate and Health Protection, first of all to bring together the evidence, and then we now have a receptive audience, I think, in the UK, which perhaps was not there before. We have, because of the focus on infectious disease, people have asked about other hazards. So now there is political interest in what we are doing on radiation and chemicals, and that's been an underinvested area. And we are now playing a key part in redeveloping both the national risk strategy. So we always had flu at the top of ours. It's now pathogen agnostic, but also in development of a biosecurity strategy, which includes that One Health angle. Next slide, actually, I think is the last one. And some of the key areas that we have done is around data and technology. So I think picking up the point about behavioural science, the COVID dashboard, which was how we refer to our national data display, was one of the most popular hits on the website right the way through. Actually, I think internationally people looked as well. But what that did, during the Omicron wave, when we had a very rapid rise, and then the subsequent one in the spring of this year, we recognised that people were actually managing, they were their own armchair epidemiologists, and without making comments or putting out strict guidance, you could see as the rates rose, a quick signal in the media, people were responding routinely. We could see on Google Travel or whatever it might be, you could see the rates of travel and interconnection coming down. So it actually became a self-management tool. And then for data linkage, two areas I just wanted to flag. For communities, for our local directors of public health who reach into communities, for example, who may be less confident about vaccination, having that detailed granular information has been really critical in getting very high rates of vaccination and protection. And then on the data linkage, which I've called systems, we were able to have some very new data linkage, partly as a result of the fact that everybody was focused, and the imaginary barriers, which are sometimes there around data exchange, suddenly fell away. And so the SARI Watch is the hospital acute respiratory infection surveillance, and then the second generation surveillance system, SGSS, is one where we get automatic uploads from all of our laboratories. So it's much easier then to do routine surveillance. And then obviously, finally, but absolutely by no means least, good data and good data linkage means that we can have a focus on all of the inequalities for health hazards, both on the services that are being provided, but actually the health outcomes that are following. And I'll pause there because I realise I'm at the end of time.
Thank you, and sorry for rushing a bit. But thank you so much. A big applause. I like this, that everybody are standing up. This gives a little bit of physical activity. That's also good for health. I was just going to ask you one question. Does it help to change minister very often? But then I was thinking that I actually know one of your previous ministers, because we had a roundtable on AMR at WHO some time back, and he's now your Minister of Finance. So more appropriate question is perhaps, does it help to have a Minister of Finance who's been a Minister of Health?
So I have learnt that I am now a very senior civil servant, and I have to answer these questions very carefully.
Okay.
So Anders, actually, what I would say is my observation is as ministers move between posts, they tend to take on the persona of the post that they've moved to. But
Okay.
I don't think it hurts if they have the understanding from their previous exposure to health discussions to take with them into the next.
Excellent. We're coming to the end, so a big thank you to all four of you, both being here and being online. I think what we have gained as public health experts and interested partners is that health is a broad area, and we have got a bit better understanding in terms of what is really impacting people's health, and also what can we do to basically to improve people's health, what is driving this. I think what I've been struck with is that a lot has been about the COVID, the medical aspects here. Not so much about climate, basically nothing about conflicts. And again, on the pandemic, a lot has been about the medical aspects here. But I think the lessons here is a little bit what we have at least been touching on, is how can we actually improve people's health by better policy coherence, better knowledge in terms of what is really impacting people's health, and see how we can mobilize our colleagues working in the climate or the urban or the food communities, because that is really where I think we can have best impact on people's health. I will finish just with a message saying that we are going to have dinner, and I would just highly recommend you to go to this place because it's very special. And I will end then also with a personal story. My grandfather, in 1920, he was a fisherman living in an island outside Stockholm. Not very different from the very remote areas in Sierra Leone where I was working. My father was delivered by a traditional birth attendant because there was no healthcare at that island. But in 1920, he was fishing, and then some of his fishing equipment got stuck in something. And those were expensive things at that time, and he was able then, because it was like after the First World War, to engage a diver. And they went down and they came up and said, oh, we have found something. And they have found 16 bronze canoes, big arms, down at the bottom, 1920. This was the sister ship of the ship where we're going to have dinner tonight. This led then to the beginning of, then there was a marine archaeologist, of course named Anders as well. Everybody in Sweden are named Anders. Anders Franzén. So when he did research on this ship that my grandfather was sort of part of actually then that they discovered, then they found in the archive the documents about the Vasa ship that has been totally forgotten. And this was in the mid-50s. So then in the beginning of the 60s, they were able then to take this ship up to the surface. And what is very special with the Baltic Sea is that we have no, what you call the worms eating. Normally, I mean, if you have a ship made of wood, it will be destroyed, but this was intact. So it's one of the largest, if not the largest ship that is still intact in the world, and it's been now extremely well renovated. So it's really, I would say, something that, I mean, people are coming from the world to come and visit and to look at it. The only thing is a little bit chilly there, so make sure that you bring a sweater, but please come. It's a very nice and a very exciting place to have dinner. So I hope we will see all of you there tonight. Thank you very much for this afternoon.